Thanks very much indeed, Sinclair, and I'm very pleased to be here with everybody today. One correction, I haven't been a pediatrician for 44 years. I've been in pediatrics for 44 years. Not quite the same thing, but as part of that was getting to know this sphere. So this is the title, and Shirani wanted us to talk about Mind the Gap, and we'll be talking to the gap, long-term healthcare in children and adolescents, and there's some details about the three of us. But perhaps we should say, what are we talking about? Is it long-term care of the ordinary child that a general pediatrician might follow through their lives? No, we're certainly talking about longitudinal care, but not for all children. So who are we talking about? So let's try and find a name for these children. These are children who are living with something that most other children don't have to live with, and so are their families. So what do we call them? Well, I'd like you to choose some names, some numbers, or some words that you think might be describing such children. We can look at this long list of things that you have probably met in discussing children with various ailments that don't go away. Some use the word handicap, others say disabled, some say non-communicable diseases and disorders and all the D words that are not favored these days. So there are many terms around these children, and some exclude other children, and some may be stigmatizing. So let's see if we can organize them in some way as we try to find a name. So on the left, we have types of conditions that children might have. In the middle, we have names that have been used as umbrella terms for children who have conditions that are not that go on for a number of years. And then on the right, we have words that in discuss explain that there's time involved. And palliative, which was on the previous list, is actually about a type of care rather than describing the condition itself. So from that long list, we've chosen long term because it doesn't have the potential stigma of chronic, which sometimes implies severe, and not all long-term conditions are severe. And the condition gets rid of all the D words and is more acceptable to many families. And you will know that many children with long-term conditions, with a huge variety of long-term conditions, which are categorized here, but deliberately I made it difficult to read because we're not trying to get to know all those diseases. We're trying to find out what brings them together. And some of those are mild, but present for years and may affect schooling. Some are moderate, some are severe from the beginning, some become severe over time. Some are continuous, some only are intermittent, and some actually remit during childhood, but are there long enough to have effects on children. So I'm introducing a term here called the non-categorical approach. I showed you a picture, a table of categories, but I'm not going to explain this term now because I would like us to think about how many children are there with long-term conditions where you work, or in South Africa, or in your country. And we use three epidemiological terms to work that out. Prevalence, the number of children with long-term conditions living at a particular time. Incidence, the number of new ones who are appearing during a particular period of time. But also with long-term conditions, we need to think about birth incidence, because we don't diagnose congenital heart disease at the time that it is born. There are congenital conditions that are only diagnosed much later. There are genetic conditions that only come together with the environment and produce symptoms later. So using these counts, you can work out that's how we work out how many there are. And why do we need to know? To show that there is a problem and how big it is. What does it look like? Who are these children? How many of them are, and how should we be providing services? And we also need to know what's changing over time, what is happening with over time. And then what are the service requirements and responses, both preventive, how do we stop some of these conditions from happening in the first place? And then how do we organize our services in order to deal with them? So it's not easy to count Can you go from door to door? If you count by going to standard surveys, particularly in countries, lower middle income countries, you're not going to find the data you require, and it's very expensive to go from door to door. So how many are we talking about? Well, the sad thing is that we don't actually know. We have about 20, just under 20 million children in South Africa, according to the census. That may be inaccurate, a bit more or less. But estimates based on international would show that 1 in 5 children have a long-term condition. If you live in an area where there's a high incidence of atopy, it may be higher, particularly urban environments and polluted environments. And amongst those, about 2 in those 5 have a severe, complex, or disabling children. So that's a condition, 2 to 4% of all children. In South Africa, it's been estimated that there are about 60,000 children born each year who survive. So that's not about the ones who are born and die very quickly, about 6% of births. And estimates of the number of children with neuromuscular, severe intellectual and sensory deficits is about 1.15 million. When we applied those figures in the western part of Cape Town, and I did the same for Vembe, but I couldn't find my slide for Limpopo. If you take the population under 14, not under 18 here, because that's the way the census counts them, you can see the 4 sub-districts of Metro West in Cape Town, and you can see how many children there are, nearly 500,000. If 1 in 5 of them has a long-term condition, then about 100,000 in half of Cape Town. And about 1 in 25 have a complex lung condition. That's around 18,000 children. That's a lot of children who need to be identified and receive appropriate care. And we'll come to what appropriate care comes to in a moment. So why do we need to have a non-categorical approach? Why do we need to count them all together and lump them rather than thinking of them as individual conditions? Well, we have the danger of getting vertical programs. So we have oncology programs and programs for cardiology and the one that we know best for HIV infected children. And therefore you often get people working in their silos and they don't take an approach that involves looking at the whole system for children with long-term conditions. We're very good at acute in pediatrics. We have good systems for that in general. We have lots of protocols and we know what we're doing. But when it comes to long-term care, we have a lot to do, and we'll come to my 2 colleagues talking about that. But really, why we have a non-categorical approach versus a categorical approach, which is counting up individual conditions, is that if you have a long-term condition, there are implications over time of you just having that condition in your life, regardless of what it is. Obviously, there is some importance between difference between a child with congenital heart disease and a child with autistic spectrum disorder, ASD, both, but very, very different conditions. But there are things that they have in common, regardless of the problem or the diagnosis, which produces needs. Because we're moving from thinking about cure to thinking about care. So in acute pediatrics, we get them in, we rehydrate them, and we do something to try and make sure they don't get it again, but they go out and we hope that they'll do well. But here we're talking about care over time, and it's a completely different kind of paradigm. Yes, acute happens during it, but it's usually symptomatic of the condition or of some other condition, but they still have the long-term condition. So in this slide, this is just an example of some of the things that are likely to be common or should be prevented from being common in all children with long-term conditions, or most of them. Possible that neurodevelopment and education are affected negatively by the presence of a long-term condition, regardless of what it is. Likewise, psychological, and not only the child, but the siblings and the parents too. Effects on nutrition and growth, overweight, underweight, feeding problems, special diets, producing psychological problems. So these interact despite the lines you see here. Secondary disability. I have congenital heart disease. My mum is not coping well. I'm feeling depressed. I'm now not going to school, so now I have another disability on top of my cardiac disease. That's depression and anxiety. There are greater healthcare needs, as well as the same ones as other children. But then some people don't want to give you a vaccination because you've got Down syndrome, and they think, whoops, we don't know whether we should give you that, and it becomes more complex. And then obviously on social functioning, whether it's in school, communities, families, and not, again, not only the child. Dad might go to work, gets out of the situation for a while, mum's in the situation all the time and is stuck at home, gives up her job, gives up her career, and so on. So there are implications for the family and health services and society. So, in essence, the non-categorical approach says the effects of the condition are more important than the name of the condition. And effects, we're talking not complications of the disease, but complications of the presence of the disease, or the effects of the complications on the child in those broader domains we've been talking about. And so it calls for a different response from families and children. If you want a definition of who's in and who's out, think of any condition that has a biological, psychological, or cognitive basis on the left there, produces limitation of function compared with peers, or in order to function the same as peers, dependency on medication, AFOs or psychological support, and a need for healthcare above those of the person sitting at the desk next door at school. So are we set up for cure or care? Are they set up mainly for cure or care for children? Are you set up for cure or care? And what do parents expect from us in terms of the emphasis of what we talk about? Are they used to talking to us about care rather than cure? Do they expect us to understand their situation? Do we allow them to talk to us? So using a non-categorical approach to provide care across the life course and to achieve optimal outcomes for these children. So it's not the fact that the optimal outcome of the organ involved, it's the optimal outcome for the child and the family. And there I will stop and hand over to Shirani. Thank you very, very much.
Thank you so much, Tony, for that beautiful setup. Um, Everything worked perfectly when I did my trial, and I just want to check if I am projecting correctly.
Yes, you are projecting, but do you mind just making a full screen? Yes, you are, Shirani.
Fantastic. All right. Before I get started with my section, thank you so much to SAPA for having us. We're very grateful. And I actually wanted to ask the colleagues in the room. I squizzed through the participants a little bit, and I see so many names and faces that I know. So I had a few questions that I wanted to ask, and I was hoping that you guys would participate and participate frankly and robustly. So the questions are on the screen, and I think Cynthia, were you going to put the poll in the chat?
Yes, I will launch the poll now.
So there were three questions that I really wanted to ask because, one would think well, let's answer. And while you're thinking about that and answering, I'm going to move on to my second. Cynthia, I wonder if you can move the poll questions to the side. Will you try?
Have they moved, Shirani?
Okay, I'm moving it to the side so that I can move on to the next slide. While you guys are thinking about that, I'm just gonna
Shirani, on my screen, it's still sitting over your slide.
Shirani, should we give them 5 minutes, 1 minute to do the
Yeah,
poll, and then
let's do that.
Yeah. So we'll just give everyone 1 minute to do the poll, and then once we've had adequate response, then I will take the poll away. 10 more seconds, everyone, and then I will end the poll. We have about half of the participants have responded. And once we get to 60%, then I'll stop the poll. Thank you everyone for participating in the poll. I am ending the poll now.
I think it's quite important to start with kind of gauging where we are as a community, because it's very tempting to look at topics like this and go, those are really nice to have. And it must be nice to do this in that other place. For example, Tony is retired now. Perhaps he has lots of time and that's why he can do it. And perhaps other people have more resources and perhaps other people are not as busy. And it's really important to focus our attention on where we are and what our resources are. We have a range of needs that children have in our country, and we simply cannot afford to work hard but not smart. Long-term health conditions tie in very closely with ambulatory care sensitive conditions, which are a range of conditions where effective and timely outpatient care can prevent hospitalizations by reducing the risk and need for inpatient treatment. We know this. It's the basis for our deep buy-in in primary healthcare. But let's just look at the numbers. In South Africa, we estimate that 1 in 5 children roughly have some kind of long-term health condition, which if we do the numbers, about 4 million children should be in this group. If we look at data from the US, we can say that 1 in 7 pediatric emergency department visits could be preventable by quality primary healthcare, and that equates to about 30 million children. There's a recent Latin American review where they did beautiful pool data about ambulatory care sensitive conditions, and they looked at a whopping 17% of their discharges and days of stay over a four-year period pre-COVID were these chronic diseases, non-communicable diseases, all these acronyms that Prof has introduced us to. But the bottom line is that scarce hospital capacity is heavily used by potentially avoidable admissions, despite these investments in primary healthcare. And so for us who work in a situation where inpatient resources are so tight, we simply cannot afford not to invest in long-term health conditions. So let's look at the poll, shall we? What were the results from the room? Poll results. Simply, what did our poll show? Where will it populate? So while those are retrieving, I'm going to tell you really what I thought that this would show. What really I believe is that the pediatric and child health community deeply, deeply values long-term healthcare. It's something that we all want to do. It's something that we all believe in. But myself as a registrar, I didn't spend that much time getting taught on how to do it. And subsequently, when I graduated and I went into my subsequent career and spent some time in private, it was quite a shock to me how poorly I could do the thing that I wanted to do so badly. And that was a tough thing. I had to really sit down and kind of figure out how I was going to upskill myself and how I was going to learn on the fly to do this thing that was so important to me. And this is quite started my interest in this field. And I'm not insensitive to the irony that a person who works primarily in an emergency department talks so much about long-term healthcare, but it is what it is. When you work in acute care, you see very clearly how the fractures in long-term care cause these urgent crises that really are preventable. So the group of courses that are presented through UCT under the banner of the Community Peds or Postgraduate Diploma of Child Health. They've developed these set of what we call C and P words. They are they are not limited, but these are just some nice little tags that we've developed that kind of encompass these ideas and concepts that we want to build into our practice. And as you go through them, you can think about them quite as a superficial or deeply entrenched into your practice, and you can think about them as an individual, as the leader of a team, or as a member of the healthcare system. So let's maybe look at some of them and see how they go. So this is a slide that I have repurposed from another publication. This is really one
Shirani,
of
we're
the
not seeing your slides, we're still seeing the poll. I'm still
It's
seeing the
interesting
poll.
because I don't see the poll.
Oh, sorry.
So I am seeing Shirani's slides. Shirani, would you like me to share the poll now?
Yes, I couldn't figure out how to do that simply. That would be
That's
fantastic.
okay. Okay, so based on question 1, so how much does the pediatric and childhood community value long-term health care? Majority of people felt that this was moderately valued or slightly valued, and that got the highest percentage of all the questions, 31% each. And then for question 2, in terms of how much time do you spend or have you spent as a pediatric trainee in a clinical setting that provides long-term care to patients? Most people said they spent between 0 to 3 months, which was 53% of the participants.
Okay.
Yeah. Interesting. And for question 3 is how confident did you feel in executing care for such patients once you were practicing independently or supervising others? And majority of our participants said they felt moderately confident. So yeah, with only 1% saying they were feeling extremely confident.
That is actually very interesting. Zontle and I had a little chat beforehand, and we were trying to guess what the average was in the platform and the different training programs. And I must say, less than 3 months was not where I thought the numbers would even out, which kind of does support what I'm saying, that the amount of formal training that you get, or even preparation that one gets for actually executing long-term care, really does need to be boosted. So my next slide was really about introducing this kind of concept of the C&P words, which are nice little hooks on which one can then layer one's practice and integrate small wins and then more substantive changes in your practice that can make you more sensitive to long-term health conditions. Just checking, you guys can see the right slide?
Yes, we can.
Fantastic. All right. So the first one, and I think probably one of the most important ones, is comprehensive. So this infographic, it comes from one of the child gauges, and it's actually about how early life can set the scene for non-communicable diseases. But I'm going to use it in a slightly different fashion here. I'm going to use it as a visual representation and how the needs of an individual with a long-term health condition can evolve over time, and how our responses to that individual must be comprehensive and they must be responsive to all those needs. So we know that many long-term health conditions have their origin or their roots before birth. We can say that these are congenital heart disease, genetic disorders. Some of them start at the onset around birth, and cerebral palsy would be like the archetype of that kind of condition. Early childhood yields an entire range of conditions with long impact. Autism spectrum. Later in childhood, we have asthma. Don't forget that we are becoming increasingly successful at many of the things that we do. We have an entire cohort of children who are the graduates of nurseries and NICUs and then emerge with long-term health conditions secondary to that. Many conditions that were previously life-limiting, the congenital heart diseases that have been fixed, cystic fibrosis, that now has a lifespan that couldn't be dreamt of when I started as a junior doctor or medical student. So many of these conditions that were quite unidimensional when we might have started training now become quite complex. Our children with epilepsy become adolescents, then they become young adults, then they become parents with children who have genetic risk for epilepsy and who need an entirely different set of counseling. So conditions can remit, they can progress, and new conditions may emerge. When we look at disease-specific therapy alone, we can have very poor outcomes if these holistic conditions are neglected. And I can give you some examples, millions of examples. But for example, if we'll take a patient with severe asthma, they may very well develop their friends of allergic rhinitis and eczema, and that we know well, and we look for those things. But equally, that patient with severe asthma can develop mental health issues, they can have a substance disorder, they can acquire new onset HIV as a teenager for the first time. So many of the conditions that we look after remit in an entirely predictable way that we can risk stratify, that we can plan for, and that we can manage secondary complications. But the full gamut of complications need to be looked for in a systemic way. So comprehensive is a difficult one, but it is the one that really we do have to strive for. Next two are challenging ones. Continuity is probably one of the ones that we struggle with the most in the public health service. It really is our Achilles heel. We know that continuity of people, of management, and of information in the child's care across the life course is really, really valuable. It mitigates waste. And when I say waste, I mean waste appointments where the doctor who's looking after the patient doesn't really know them that well, futile or repetitive tests where we do things to give us information that we already know. When we start treatment options that have low chances of success because they've been tried before or the patient's profile doesn't fit that particular therapeutic option. So continuity of care really mitigates waste, and most importantly, it builds trust with our families. When we have trust, we have partners in care. When we have trust, we have adherence. When we have trust, we have an engaged child and family. So continuity is such an important thing to say, but such a difficult thing to actually achieve. The public health system, we know it, and even private, we are strained. There's often too few staff to go around. And it's one of those things where the workarounds, electronic records, patient health records, motor health cards are really nice to have, but they don't address that underlying need for continuity of care. If we move along to another one, communication, that's another C word. It works beautifully to demonstrate the kinds of concepts that I'm thinking about. We can use verbal and written means of transmission of meaning and information for the child, the family, the healthcare team, and other sectors. So pediatrics is interesting. Pediatrics is a duo that becomes with time a trio. With time, with emotional development, emotional maturation, and that child who was the dependent over time becomes an active participant in their care. But we don't just communicate with the child and their family. We communicate with extended families. We have to communicate with schools to become a vital partner, with teachers, with coaches, with sports. We have to communicate with other healthcare workers with other disciplines within medicine, and increasing with clinicians who are out of our comfort zone. And traditional complementary medicine is an important part of the total healthcare dynamic in South Africa. And increasingly, we have to engage outside of what makes us comfortable. And I've said blue whale because it's the biggest animal that I can think of. But social media is a sphere that increasingly is impacting on our patient care. It has an enormous reach. Very often it's the voice that our parents and our patients reach to first for getting information about healthcare related issues. So communication as a C word is a vital part of how we manage long-term health conditions. Community linked. This is another interesting one. Services, we speak about this globally, but services need to be in touch with and they need to utilize community resources. This is not just social workers and care dependency grants, which is the things that we reach for easily. We need the full gamut of what's out there in the community. Are there transport supports? Are there housing modifications that we can ask a local community to assist us with? Is there community-based care that can augment what we do at facility level? Are these via the Department of Health? Are they via NPOs? Let's not forget about the value adds to build joy into patients' lives. There's leisure, there's activities of building cultural activities, building skills. Peers are an important part of the community. The more we entrench our patients into their community, the better they are managed to be, avoiding stigma, and the more we have an inclusive community. Another good C word, coordinated. Now, as we go along, we are getting to C words that are increasingly complicated to actually achieve. So we know that coordinated care is important. We need to have planned, seamless, and efficient care across different sites, across different sectors, and among all the professionals involved in a child's care. And just from no enterprise or task that's got multiple role players can prosper without somebody to hold the center. Easy said, but difficult to do. And again, with pediatrics, trios becomes multiple role players. As the child matures, school, home, hobbies, vocational training, um, potentially even career opportunities become increasingly complex and can no longer take a secondary or backseat to appointments. I need you to come Monday, Wednesday, Friday because you need to see the general peds, and then you need to see the social worker, and then you need to see someone else. And it's very easy to make healthcare become the dominant part of the patient's life. I got my slides a little bit backwards, so I'm going to go back just for a second. Increasingly difficult things. Things are easy to say and more difficult to do. So I'm going to show you a paired set of C words. I'm going to start with the one that I enjoy most, capacitated. This is a word that's really, really important to me. It's this process of, well, the strict definition would be getting to a point where you have somebody who's capable of performing the actions that are expected of that person, the child, the family, the professionals, and the system. It's really the more evolved version of patient education, and it's this iterative bilateral exchange, information, skills, resources, strengths, and the end point is a partner in care. When you can achieve that point with the family, it really is wonderful. But when you can achieve that with the family and your patient, you really get somebody who is empowered emotionally. And that last phrase, what I know and who I tell, is a really important thing because I don't always think about it very, very much. But let's think. You have a patient who has asthma in front of you. You've done your patient education, you've spoken to the family, you've shown them the inhalers. What is that child going to tell the people at school tomorrow? What do they know? What have they internalized about themselves, their body image, their self-esteem? Who do they share this with? What do they share? These are very important things for little people and bigger people. And Zakira will touch on this much more in the adolescent population. But this idea of achieving a capacitated family and patient is such an important thing. But how do we achieve a capacitated patient when we don't have a capacitated environment? Let's just think a minute. What is it like to walk through your system or your facility in a patient's shoes? Is the physical building easy to navigate? Do they have disability access? Is there clear signage and a rational patient flow? If you can't actually find your way to your healthcare workers, how safe do you feel? How empowered do you feel in that space? Language, literacy, actual literacy to follow the science, and health literacy to follow the information that is being presented to you in the pamphlets and the signage, in the websites that you might be provided. All of these things are quite deeply entrenched with privacy and dignity and respect, and those Butterpela principles that we talk about a lot, and that really one cannot expect to get to a capacitated patient if one does not have a capacitating environment. And here we add another layer of complexity to the CNP words. There's the individual, the relationship between yourself and your patient that you can work on and you have agency over. But then there are also issues around your facility, around your healthcare system, around our national systems that add an increasingly complex layer to these CNP words. And what we need is to really work on entrenching them in our systems at all levels. And that is the end of my slot. I'm going to hand over to Zakira.
Thank you so much, Shirani. I'm just going to share my slides. Right. Zinhle, can you just confirm that you can see my slides and that you can hear me clearly?
Yes, we can see your slides and hear you nice and clear.
Thank you so much. Thank you. Thank you everyone for being here. I know it's almost, it's almost 6 o'clock on a Wednesday afternoon. So we really do appreciate everyone taking time out after a really busy day at clinic or practice and choosing to come and engage with us. I think on a topic that clearly Shirani, Tony, and I share some very passionate views on. So a huge thanks to Tony and Shirani for setting the stage as beautifully as they have. What I'm going to do is I'm just going to shed some perspectives on the adolescent that's living with a long-term health condition. We'll just wrap our minds a little bit about some of the challenges that this particularly vulnerable group of patients face, and then we'll chat very briefly about the ethics of I would say a hot topic, and that is the transition of adolescent patients from pediatric care to adult care. So just, off the back of what Shirani and Tony have said, I think we can all agree that with all the advances and the strides that we've made in healthcare, more and more children with chronic diseases are now surviving into young adulthood. We're now seeing survival of these young patients that have increased up to 90%. And these young patients with long-term health conditions are living well beyond their 20th birthday. So what this does is it actually presents us with an increasing population of young people with chronic illness or disability. And obviously they have a very, very unique set of healthcare needs. So as healthcare service providers, we may be very familiar with managing the complex medical aspects to their care, but often it's the broader psychological issues for this particular group of patients as they progress through adolescence that may actually be less well understood. So just by way of a quick overview, we all know that adolescence is known to be a period of growth and development. It's characterized by a gamut of physical, emotional, and mental changes, which sees that young child transition from dependence to independence, with the adolescent now required to adopt a multiple and multitude of new social and emotional roles. I like to think about it as an adolescent having a brain under construction and a body that tends to follow suit. So for the healthy adolescent, it's challenging enough period to go through physiologically. So one can only imagine what it must be like for an adolescent or a teenager that's actually living with a long-term health condition. So very quickly, just to cast our minds and look at some of the developmental tasks of adolescents. So this particular group of patients, they over a period of spanning 9 years, because the WHO defines adolescence as between the age of 10 and 19. And we know that this period is actually a lot more fluid. And we tend to know that adolescence actually only really complete at the age of 25, when that frontal lobe is actually gained full maturity. But in that time, the young person is supposed to achieve emotional independence from their parents. They are supposed to form mature relationships with peers. They need to start preparing for adulthood. They start thinking about long-term marriage, family life, and careers. They achieve and actually consolidate masculine or feminine roles. There should be an acceptance of one's physique. There's an acquisition of a set of personal standards as a guide for behavior. There's the development of, very importantly, social and emotional intelligence that happens during this time. And they should be able to learn how to cope with success and failure. And also, very importantly, they need to learn to develop problem-solving skills. So it's actually really a big ask of these young people. So what are some of the challenges that adolescents who are living with long-term health conditions face? So there are challenges around independence. These adolescents are constantly struggling with independence. So on the one hand, they have this desire to acquire independence. As I said, it's one of their developmental tasks. But often their illness or their condition will tie them physically, emotionally, and financially to their parents. And then there's also this concept of transition. So the transition period is vital to maintain self-esteem and confidence, but that actual transitional period itself may be fraught with lots of difficulties for the adolescent patient. So they have to deal with the effects of that chronic condition itself, which may impact normal growth and development, their muscle strength, and also their sexual maturation, which in some cases may actually be delayed, and in other instances may actually be precocious. So, self-esteem issues may arise as the adolescent struggles with visible changes in their physical appearance that's actually caused by the long-term health condition, which put them at risk of social adjustment difficulties, further exacerbated by society's almost abnormal focus on physical attractiveness. So this is an issue that's become even more relevant today, where the impact of social media on young adult mental health has clearly been highlighted as being deeply problematic. So what are the features of a long-term health condition? As you guys have been told, it's one that has a physical, cognitive, or mental basis, which can potentially affect a child's physical and or psychological development for more than a year, sometimes for life. It requires ongoing health and other services to function optimally, and as a result, it requires continued, coordinated, and comprehensive health care, as Shirani mentioned. They typically have an unpredictable cause with long-term dependency on treatment or technical aids or physical assistance that need behavioral adjustments and a high commitment to self-management strategies. So these long-term health conditions, they may place extensive demands on the adolescent by way of scheduled medication, special diets, regular exercise, doctor visits, and monitoring. They invade actually every aspect of an adolescent's life, on the school front, the way they eat, their diet, sport, work, travel, dating. And what I've actually seen just from chatting to my colleagues is that there's this growing perception among pediatricians and doctors in general that the adolescent group of patients are extremely difficult and that they are non-compliant and oftentimes that they are challenging and spoiled. And so nobody actually wants to take charge of them. So we'll just look quickly at some of the issues and we'll explore this concept of compliance in the adolescent patient. So what are some of the factors that actually affect compliance? So what we know is that several studies have actually shown approximately 50% of adolescents with long-term health conditions do not comply with recommendations. So there is actually some truth to the assertion that they are non-compliant or difficult. But there are multiple factors which affect compliance. And these could be developmental issues, they could be medical issues, demographic issues, cognitive issues, emotional and motivational factors, the lack of peer support, as well as the quality of interaction with their healthcare providers. All of these factors obviously overlap and they have to be considered in tandem with each other. So what are some of the actual factors that we know affect compliance directly? So what we do know is that adolescence itself, being a teenager itself, is not a reason for non-compliance. As I said earlier, it's characterized by that specific challenges related to their brain growth, biological growth, psychological, and social development. And what we know is that teenagers actually want to start asserting control over their treatment that they've been living with for many, many years. And so we typically tend to see in the teenage years, the wheels tend to come off. I've often heard that term bandied around. You know, the doctors would say, you know, this child is doing so well and I actually don't know what's happened. Things have just... I think it's part and parcel with where they are at in terms of development, but it's also part of this talk. It's about finding the tools and the strength that we need about how we can actually support them through this period. So other issues, for example, the disease and the treatment that they're living with may directly interfere with their physical growth by altering hormonal balances. For example, chronic and long-term high-dose steroid use in, for example, juvenile rheumatoid arthritis, or even asthma for that. So living with the effects of the side effects of the treatments that they are meant to be on could lead them to be non-compliant. Then long and repeated hospitalizations may affect academic progress and peer relationships. And what we know is that obviously the onset of puberty itself may well result in metabolic fluctuations. And for example, in our diabetic teenagers, these could result in reduced insulin sensitivity, which could complicate both the treatment and the supervision of the diabetic adolescent, which could result in compliance issues. So as I said earlier, the changes in physical appearance and that increased comparison that they make with their friends or their classmates can lead to heightened awareness of potentially constraining physical and social side effects of treatments, which may actually lead the teenager or the adolescent patient to question the value and the necessity of the medical instructions or the treatments that they've been offered. I think it's really important to remember that the adolescent with a long-term health condition still desires to reach the same developmental outcomes as their healthy peers. And in their quest for independence from parental influence, they will spend more time with their peers if they are able to. They may adopt new values and standards, which may obviously affect the family equilibrium as a whole. So what are some of the other factors that we need to consider? So studies have shown that adolescent poor compliance was found to be associated with a longer duration of the disease, an earlier age of onset of the condition, later referral to specialists, fewer clinical visits, and shorter duration of specialist care. So what we know is that lack of knowledge or misunderstanding can impact adherence. The desire to fit in with peers can lead to them hiding or skipping their treatments. Complicated treatment regimens or side effects can be a barrier to compliance. Teenagers are just busy, so sometimes they just forget. They may forget their appointments or they may forget to take their doses that they need to. And then obviously the mental health impact of living with that chronic illness. So what we know is that anxiety, depression, and denial can impact adherence negatively. Oh. So, knowledge about an illness and its treatment is essential for compliance, but information alone is not enough to promote behavioral change required as part of management. For an adolescent with a long-term health condition, attitudes to the personal meaning and significance of the condition, as well as therapeutic motivation, are the most important factors that actually affect compliance. So disturbances of emotional well-being, these may include fear, guilt, shame, depression, and anxiety, are much commoner with adolescents living with long-term health conditions compared to their healthy counterparts. Studies have also shown this group to have lower self-esteem and prolonged social dependence compared to healthy teens. So the adolescent with a long-term health condition is therefore at higher risk of mental health issues, and so each health visit should present an opportunity for mental health screening that we should all be doing whenever we come in contact with them. So what about family support? The role of family can never be underestimated, as family provide tangible support whilst friends provide companionship. So family conflict and poor interpersonal relationships between the teen and their family members is definitely associated with poor compliance. It's critical to incorporate culturally based perceptions of treatment and illness, as these will impact heavily on compliance too. Parental supervision is key to improved compliance, but as the adolescent grows, striking the balance between supervision and the dominating care of the adolescent is critical. And this may actually be a very difficult process for many parents who have been carers of these teenagers for many years, and suddenly they start feeling unappreciated or actually quite redundant. So many struggle to actually hand the decision-making power over to the adolescent. And as healthcare providers, guiding the parent through this stage, which requires planned self-care, the provision of regular positive feedback, and often the provision of rewards for good compliance, has actually been shown to be effective. So what about friends? So we know that close friends and peer relationships are an important source of support for adolescents with long-term health conditions, especially during this period where they have those developmental tasks to tackle as well as disease-related challenges to face. The role of friends may be both positive and negative though. Many teens are embarrassed to share the details of their long-term health condition with their peers, and they would much rather omit or skip treatments in order to not bring any attention to themselves. and encouraging healthy dialogue and the destigmatization of long-term health conditions would aid this process and provide the adolescent with much needed relief. So how best do we promote compliance in adolescents with long-term health conditions? So to improve and promote compliance amongst adolescent patients with long-term health conditions, greater attention needs to be paid to the adolescents themselves and especially their lifestyles. As healthcare providers, we need to understand that the long-term health condition and its treatment is only a part of that child's life. They need to be looked upon as individuals with a chronic disease or condition who are passing through a particularly challenging period in their life. Traditionally, patient education has focused on attaining physiologic improvements through changes in knowledge and skills, which leads to improved self-care, improved medication use, a reduction in complications, and enhanced quality of life. With adolescents, however, educational programs need to be based on an appraisal of each adolescent's needs. In other words, it needs to be individualized rather than adopting a one-size-fits-all approach. So educational interventions that emphasize knowledge, behavior-centered interventions like learning a new behavioral skill, self-monitoring, and organizational interventions, for example, treatment planning and scheduling, the provision of incentives and rewards, are generally most effective in promoting compliance in this group. With regards to goal setting, adolescents need to be involved in the goal setting process right from the start of their treatment, even if it means that initially goals are set at slightly lower than normative values. This approach should be taken with care, though, as the risk of complications are higher sometimes with too lenient an approach, for example, with teenagers and the development of diabetic complications. So adolescents with long-term healthcare needs have other needs, personal priorities, and social roles that they want recognized in their care. And the question is how well healthcare regimens can be adjusted to the adolescent's normal lifestyle. When the required degree of lifestyle change is perceived as being too high, it may result in reduced compliance rather than increased compliance. So there has to be a constant reevaluation and fluidity to the transaction between the healthcare provider and the adolescent patient. So healthcare providers need to involve family and significant others in the care of the adolescent patient whenever possible and only if acceptable to the adolescent. The quality of the family support and role should be evaluated continuously with necessary adjustments made as we go along. Adolescence and transition may be particularly stressful for the parents of children with long-term health conditions, especially where they've been the primary carers to date. And parents may well need support and counseling through this phase as they learn to relinquish power and accept a decrease in the extent of control over their child's life. And as the adolescent progresses through this period, a very necessary shift from parent-driven health visits to self-driven health visits need to happen. Supportive rather than controlling relationships among the adolescent, their parents, and the healthcare provider should be encouraged. So in terms of us as healthcare providers, what is our role? We have to constantly look at the quality of our interaction with our patient. We have to look at whether our healthcare systems are functioning, and do we have a relationship with our adolescent patients which actually allows the adolescent to be actively involved in care decisions, because we know that these are going to be associated with good compliance and long-term better outcomes. Conflict with healthcare providers were commoner in adolescents with poor disease control, and you'll often find an adolescent patient may actually lie, especially when he's just trying to avoid being nagged at by his or her doctor. So the other important thing that adolescents with long-term health condition and adolescent patients in general really value is the concept of confidentiality. They really need to have our assurance that what they tell us stays with us. And obviously confidentiality has its boundaries, but that's a different talk for a different day. So we need to start we need to remember that health care of our adolescent patients should not be limited to illness care. It should encompass the wider domains of health as encompassed by the WHO definition of health, which is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So early discussions around transitional care need to occur with the family so that when the adolescent is ready to be moved across to adult services, this is neither unexpected nor resisted. Most families need time to adjust to the concept of transitioning to adult services, and early initiation of transition planning is associated with increased likelihood of success. So what then are some of the ethics of transition? And should we even be considering the ethics of transition? And absolutely yes. So in terms of autonomy, children who are growing into teenagers and then reaching adulthood, they bring to mind that concept of autonomy. So as parents and providers learn to accept the choices that are being made by the young adolescent. Much like parents, we as healthcare providers bear responsibility to develop trust with our young patients. And through this process, the young patient will gain the knowledge and the confidence required in their journey to adulthood and beyond. So younger patients need a lot of time to process change. So conversations about transition are best held early and often. And the general recommendations is that we start having these discussions around the age of 11 already. Practice makes perfect as patients gradually start taking ownership of their medical conditions and they learn to use the resources that are available to them. So true autonomy can only exist when one understands all the rights and responsibilities allotted to an individual and then exercises them with purpose. Then we talk about justice for all. So in many cases, a decision of best interest can be made almost unanimously amongst a care team. And when considering the best interests of society at large, risks and benefits are continuously weighed to maintain a careful balance. And the system of justice gives everyone the freedom to pursue their goals with the knowledge that all resources will be allocated fairly. So justice in healthcare is no different, and we should actually expect no less. Fair distribution of goods and services results from accurate assessments of need and priority of service delivery. And the needs of an adolescent with a long-term health condition are continuous and they may increase and change over time, in contrast to those of an acutely unwell child. Both levels of care are important, and failing either vulnerable population is a complete disservice to our system. So justice in healthcare is achieved when patients are able to access and use the appropriate services at the right time. An appropriate transitional care for a young adult with a long-term health condition goes far beyond hospital doors. Educational outcomes and professional success achieved in adulthood are tremendously impacted by the care that they actually receive during this transitional period. When the health system, parents, and the school system together work to ensure continued learning and access to educational opportunities, for example, for a child with a long-term health condition, we are then taking active steps toward independence for that child as they move into adulthood. So justice as an ethical concept is in jeopardy when a patient with a long-term health condition becomes a danger to themselves and a burden to society. We then consider non-maleficence. As healthcare providers, we practice non-maleficence daily. We consider the potential harm to a patient with every decision that we make. Patients have not taken any oath to protect themselves, and as a result, they may make lots of questionable choices for a variety of reasons, and this is particularly prevalent in the adolescent group. So part of developing independent young adults involve creating systems and putting boundaries in place. Parents and healthcare providers must allow that young patient to gain increased levels of freedom in preparation of adulthood, but the boundaries need to be in place as well. So in the process of transition, the care team must foster an environment where patients can develop a sense of non-maleficence to apply to their own care. And then finally, beneficence. The concept of beneficence and non-maleficence prescribe balancing the good we do for our patients with the potential harm that doing so may entail. Transitional care is an example of an action whose benefits far outweigh any potential harm. In fact, if the transition plan is properly executed, there will be no harm in the sense in which maleficence is generally understood. So taking action toward the good of the patient actually encapsulates beneficence. So what are the practical guides to transition or transitional care? So very simply, I believe where there's a will, there is a way. And all it takes is a concerned and determined pediatrician, a like-minded adult physician or subspecialist, and some determination. And what I encourage, and for those of you who attended the SAPA Congress last year, my talk was entirely on transition in adolescent care, is that somebody needs to put the first brick down and start building the bridge. We need to start small. What we like to do is the idea of having combined clinics at the pediatric service. So basically, you invite your adult counterpart to the pediatric clinic. So the child and the family see the new face, but it's in the same place, the old familiar pediatric hospital. And then you have a similar combined clinic at the adult clinic where the pediatric doctor joins the family at the adult clinic. So it's the same face, but in a new place. So they've now moved on to the adult hospital, but they're still seeing their pediatric doctor once or twice as they make the move from pediatric care up into the adult service. So this is actually just the model of a very successful transitional process that has been put into place by the renal team at Red Cross and Groote Schuur Hospital. And as you can see, there's different focuses, and it looks at pediatric focused care, which looks at that early transition discussion between the age of 10 and 12. And if you look at who, there's still full supervision coming from the parents, but child progressively starts understanding that things are going to change. Very much the focus on the social aspect would be on maintaining the child in school, continuing and ensuring that there are no gaps in education. We then look at the middle transition phase of adolescent or transitional care between the age of 13 and 15. And now you see supervised autonomy taking place. The chronic kidney disease diagnosis is, the child is given education about the chronicity of his or her illness, made to understand what constitutes symptoms that would require medical attention, etc. They are taught how to identify their medication. They are actually encouraged to help prepare their pill box for the coming week. And so gradually they're starting to grow into the role or become more autonomous in terms of their health care. And again, because this is still very much high school period, the focus is very much on schooling. You then look at the late transition period. So these are the older teenagers, at least grade 11 and up. You now have autonomy with support. So they can come, they start attending the adolescent clinic, which is either at my center or up at Groote Schuur, where there's a dedicated adolescent center. And these visits are encouraged to be taken on a more independent basis. So they know about their illness, they can tell you what their medication is, etc. They know their doses, etc. And we start having discussions with them around their career aspects, and we link them up with social workers, etc., to ensure that all of these issues are addressed timeously. Finally, we then move into the young adult focused care. So these are our school leavers. And still the young adults, again, they are now attending or should be attending clinic alone. Many of them do still come to these clinics with their caregiver or their parent, and that's okay because many of them are not quite ready to do it on their own yet. But that's the whole point of having transitional service. Everybody's at it at a different pace, and we allow everyone to achieve these goals at a different pace. So finally, what it takes is a lot of hard work. It takes a lot of communication, and it takes a multi-team approach. It's not difficult, and it can be done. And I encourage anyone who is even thinking about it to just jump at it and do it. It's so totally worth it. Thank you so much. Thanks, Inhle.
Thank you all. Thank you, Zakira. Thank you all to our speakers. You guys have been so insightful, and thank you for sharing your expertise. You know, the one thing that we all realize from this talk is that long-term healthcare remains a critical gap in childcare, and that one we are all as pediatricians responsible for to recognize and address in our daily practice. So in terms of the Q&A, we have Marco who's made a comment, and he makes the point that, you know, as long we need the Department of Health to fund adolescent care, and unless that is done and funding is directed to adolescent care, we as pediatricians will not win the battle to improve the resources for adolescents with long-term health conditions, and that we all must lobby and we all must be advocates for this. And, this is speaking on the broader terms in terms of government and what government should be doing. But I'd like to pose a question to our panelist to ask if you could leave clinicians with one actionable change that they could implement in their practice starting tomorrow, what would it be to take away this feeling of feeling helpless when we realize that this is a bigger health issue, but on a smaller scale, on an everyday scale, what would you leave, the clinicians, our listeners, with one actionable point that they could address or implement tomorrow?
May I say something? And
Yes,
maybe
go
many
ahead.
people do already do this, but it's engage with the child from the start. Um, they are going to be your partner for many years. You need to hear them. You need them to get used to you. Now, we, as pediatricians, which many of us are, that's should be what we are doing. But now we're doing it for an extra purpose, which is to engage over many years with this young person, and they feel that they can be engaged and can be heard. It's the C word of communication that Shirani mentioned. So we need to practice that. And with the adolescents, that's particularly important. But it's much easier if you've done it when they're children to do it when they're adolescents. Thank you.
Thank you, Prof. Shirani, what would be your actionable change that you think pediatricians should implement?
You can see I've worked with Tony for a long time because I was going to say it very similar because we've got a session in the course. It's called Hearing the Voice of the Patient. And when you actually do that for somebody with a child and a family, you realize how limited our knowledge of patients are and how much they shield us from the unpleasant realities of their life. But I'd actually take that one step forward, is hear your patients and actually speak with your junior doctors. They come into the profession without our years of knowing this, and they'll ask you the most interesting questions like, why can't we do it this way?
Mm,
And so innovation and small changes, that kind of that discipline of let's change one thing so that we can have a better outcome. And we trial it. You plan, you do, you study, and then you change.
yes.
It's too difficult to move our system on block,
Mm-hmm.
but we can move in iterations, and it's that iterative changes that builds enthusiasm and like, yeah, this worked. Let's try one other thing. And many of quite a few of the quality improvement projects that we've got going at the moment at Red Cross have come from our interns, our cosmos, our medical officers. They come into the system, fresh eyes, fresh ideas, like the
Mm-hmm.
adolescence that Zakira was talking about. And they go and they challenge us. And that's a C that we sometimes talk about. Challenge isn't bad. Sometimes challenge is good. It's exciting. It's growth. It's new ideas.
Thank you for that, Shirani. Zakira, what would be your one actionable change?
I think that sorry, I missed the first part of the questions, Actually, I had to answer my door. Apologies for that.
No
So maybe you
problem.
maybe you just need to repeat the question before I jump in.
So the question is, if you could leave clinicians today that are listening on this webinar with
Yeah.
one actionable change that they could implement tomorrow, what would it be? What would be that one thing you would leave them with?
I think upskill yourselves. All right. I think many people are scared. For example, I find myself in the adolescent space now. And in the beginning it was daunting. I think I came into that space also with some of the preconceived notions and ideas around the adolescent patient, etc. So I would encourage anyone and everyone to just upskill themselves, seek the knowledge that you need, and don't be scared. Just,
Mm-hmm.
be that vehicle for change, be that engine for change, because that's what we need. The children deserve that.
Mm-hmm. That is so true. We are out of time. I'd like to thank you all for all your input and all your expertise that you've shared with us today. And I hope to all our listeners that this webinar is a call to action, and that as pediatricians and pediatric health professionals, we must actively close the gap in long-term healthcare and make sure that our children are not lost in the ether out there, but we mind the gap and we play those advocates.
Beautifully said.
Unfortunately, thank you. Unfortunately, we are out of time now, but I'd like to thank you all for listening and thank you to our panelists for joining us and participating in this webinar. And we will see you next month on